All right, let's jump straight into this explainer. We're running a high-yield, high-velocity simulation today, targeting some incredibly complex pharmacological and diagnostic mandates in ocular pathology. This is strict, peer-to-peer, clinical-grade analysis for the focused learner. We're completely skipping the basics and going straight for the discrete management steps and those tricky clinical traps. Let's get to it.
Module 1, CMV retinitis and immunocompromised kinetics. Okay, so the absolutely crucial point here is the strict viral threshold. CMV retinitis is an opportunistic infection, and it explicitly attacks HIV patients only when their CD4 count drops below 50 cells per microliter. You've got to commit this absolute number to memory. It is literally the gateway marker for this pathology.
Now, I really want to emphasize the clinical silence of this disease. This destruction is utterly, completely painless. It entirely lacks any associated keratitis or conjunctivitis. When you look at the fundoscopy, it strictly reveals these characteristic fluffy yellow-white patches of retinal opacification, and they're accompanied by massive, severe granular hemorrhages. And this brings us right to the pharmacological mandate. Immediate systemic intervention is absolutely non-negotiable here if we want to halt the necrosis. You must initiate systemic antivirals and strictly utilize either ganciclovir or foscarnet. Your standard therapies, they simply won't work, and we'll break down the exact biochemical mechanism of why that is in just a second. Let's break down the clinical variants here. We're isolating the exact differentials. Both CMV and herpes simplex cause retinal necrosis in advanced HIV, but here is the key. CMV is perfectly painless with massive hemorrhages. HSV, on the other hand, presents with severe inflammatory eye pain, active keratitis, uveitis, and widespread pale peripheral lesions with central necrosis. The presence or absence of pain is your strict clinical discriminator here. All right, let's move to our first integrated assessment and apply that threshold and presentation directly. We have an HIV patient with a CD4 count of 30 who complains of painless, blurred vision, and new-onset floaters. Fundoscopy shows those classic yellow-white retinal patches. So, what's the most appropriate next step in management? You've got to discriminate between these 5 distinct options, and it's all based on the exact viral enzyme profile. A. Intravenous acyclovir. D. Intravenous ganciclovir. C. Oral valacyclovir. D. Topical corticosteroids. Or E. Oral fluconazole. Take a mental lock on your answer. If you picked B, you nailed it. And this brilliantly illustrates the biochemical mandate. Ganciclovir is required precisely because CMV lacks the thymidine kinase necessary to phosphorylate and activate standard guanosine analogs like acyclovir. That makes choices A and C completely ineffective. Choice D, corticosteroids, will dangerously exacerbate active viral replication, so that's out. And choice E, fluconazole, that's an antifungal, which is entirely useless against a human herpes virus. Module 2, Amaurosis fugax and atheroembolic dispersion. 10 minutes. That is the classic duration of amaurosis fugax, a profound, devastating, but strictly temporary monocular visual loss. Let's look at the exact mechanism. Amaurosis fugax is essentially a retinal transient ischemic attack. It's driven by displaced microemboli originating from atherosclerotic plaques right at the ipsilateral carotid artery bifurcation. Patients will classically describe this event as a curtain falling down over their visual field. But once the atheroembolic clot breaks up and disperses, blood flow is completely restored, lifting that visual curtain. Which brings us to a strict diagnostic mandate. Because the direct source of this embolus is the neck, identifying the atherosclerotic plaque burden at the carotid bifurcation immediately is absolutely critical. This transient event is an absolute warning sign for an impending massive cerebral stroke. Emergent evaluation with a carotid duplex ultrasound is strictly required. Pay strict attention here because both of these pathologies mimic a falling curtain, but the temporal nature strictly separates ischemic transience from a structural detachment. Amaurosis fugax is transient, right? It resolves completely as the embolus breaks up. Retinal detachment, though, is permanent and progressive. It features flashes of light, floaters, and an elevated retina with visible folds or tears on fundoscopy. Let's apply this diagnostic mandate to a specific clinical scenario. A 65-year-old male reports a 10-minute episode of complete blindness in his right eye, describing it exactly as a curtain falling. His vision has now fully returned to baseline. What is the strictly mandated next step in diagnosis? We have 5 competitive evaluations here, but only one isolates the exact hemodynamic origin.
A. Transthoracic echocardiogram. B. Carotid duplex ultrasound. C. Temporal artery biopsy. D. Fluorescent angiography. Or E. MRI of the brain. The correct answer is B. Carotid duplex ultrasound is the exclusive correct answer here because the microemboli originate directly from the ipsilateral carotid atherosclerotic plaques. Choice A, the echocardiogram, evaluates cardioembolic sources, and those are secondary to carotid disease for this precise presentation. Choice C, temporal artery biopsy, is for giant cell arteritis, which presents with jaw claudication and permanent vision loss, not transient. Choice D evaluates the retinal microvasculature, which completely misses the proximal embolic source. And choice E, an MRI of the brain, evaluates established cerebral infarctions, again missing the immediate next source entirely.
Module 3. Eyelid glands and neoplastic traps.
Notice the clinical shift here. We're dissecting focal lesions now. We transition from an acute, painfully tender, purulent Staphylococcus aureus infection in a hordeolum, commonly known as a sty, to a chronic, sterile granulomatous reaction in a chalazion. A chalazion manifests as a completely painless, rubbery, hard nodule.
Now listen up, because this is a massive trap. You cannot assume a recurring painless nodule is benign. A persistent or recurrent chalazion strictly requires histopathologic examination to rule out underlying meibomian gland carcinoma, also known as sebaceous carcinoma or a basal cell carcinoma. Before we integrate that trap, look at this topographical variance. Differentiating purulent infections is strictly locational. Hordeolums are a focal gland abscess right at the lid margin, while dacrocystitis is exclusively located at the medial canthus over the lacrimal sac, presenting with swelling and purulent expression there. All right, let's lock in that neoplastic red flag with this final integration. An 82-year-old patient presents with a recurrent, painless, rubbery hard nodule on the upper eyelid. It was previously treated with warm compresses, but is returned in the exact same location. What is the strictly mandated next step? Here are your 5 management options for this recurrent nodular lesion. A. Incision and curettage. B. Topical tetracycline application. C. Tissue biopsy. D. Systemic corticosteroids. Or E. Observation and reassurance.
If you went with C, you're right. Tissue biopsy is the absolute correct choice to rule out basal cell or sebaceous carcinoma in any recurrent chalazion scenario. Let's look at the noise in the other options. Choice A, incision and curettage. While used for an initial chalazion, completely misses the critical cancer diagnosis in a recurrent presentation. Choice B, topical tetracycline, is entirely useless for a sterile granuloma or a neoplasm. Choice D, systemic corticosteroids, is just misguided therapy that fails to address the obstructive or oncologic pathology. And choice E, observation, dangerously ignores a potential underlying malignancy.
We'll close this explainer with a strict clinical maxim. Basal cell carcinoma is the most common malignancy of the lid margin, and it can clinically perfectly mimic a benign recurring chalazion. Never delay histopathology when a standard eyelid lesion refuses to resolve. Master these strict diagnostic and pharmacological mandates and keep your clinical differentials tight.